Yep, I can see it. Take it away.
Thank you very much. I see a lot of familiar names on here, so I'm sure we've all met at some point. If not, my name is Dalton Gifford. I'm one of the PAs here in the Department of Pulmonary and Critical Care. You may see me on 9100 or at some points all over the place with triage. So I'm sure we've met before. If we have, it's great to see you here. Hopefully you guys are doing well. So we'll get started. Hopefully try to get through some stuff and hopefully not make your evening too miserable. Okay, so let's every one of you again, I recognize almost all your guys' names. So everyone here has seen sepsis or septic shock at some point. If you've worked in UK in the past or currently work at UK, obviously we see this nearly every single day. Just a couple quick statements. I think we all kind of get jaded or blinded by sepsis because we see it so frequently, and I feel like we do such a good job with it that maybe some of these statistics aren't necessarily true for us. But overall, what the CDC says on sepsis is, 1.7 million adults get it every year. 350,000 who develop sepsis die during hospitalization or sent to hospice. 1 out of 3 deaths in the hospital are due to sepsis. Nearly 87% start before the admission. Again, I feel like we do a pretty good job here at UK doing this. You guys are fantastic at your jobs and recognizing things and really stepping up and managing things. So again, I feel like we do pretty well. But some of the things that have kind of helped us improve treating sepsis and or decreasing our morbidity and mortality. Electronic medical records. I'm sure you guys have seen on Epic. There's like a tool now that they have added into Epic where it'll flag like if they believe the patient's septic and stuff. Sometimes it'll alert you when you open the chart, or it may have a special flag next to the patient's name or medical record. So obviously these are helpful. And then surviving sepsis guidelines, which we'll talk about, and then standard operating procedures and things at the hospitals. So here's a case that is probably all too familiar with all of you all. The 45-year-old with end-stage renal disease gets dialysis Monday, Wednesdays, and Fridays. Hypertension, hyperlipidemia, and CAD. Obviously, they're in Kentucky. Who presents the ED today with concerns of shortness of air and feeling weak. Here's some vital signs for you. So heart rate's a little elevated, blood pressure's a little soft. Looks like they have a fever, and they're tachypneic. Exam's pretty unremarkable for now. And then additional values look pretty decent for now as well. Obviously, if we look down here, we can see they have a white count of 26. Hemoglobin's a little touch soft. K's a little up. BUN and creatinine's not the best, but here we are. So this is probably something you guys see on the day. Let's talk about how we diagnose sepsis, right? So sepsis is ultimately this big inflammatory response which releases all these cytokines and other toxic pro-inflammatory mediators, causes this widespread vasodilation and all this stuff. I didn't put a slide on pathophysiology because I figured at 5 o'clock in the evening, no one wanted to do that. So you guys have all been through school. You all know what that is. But let's kind of talk about some of the things that we need to talk about for at least the ICU. So SIRS or systemic inflammatory response syndrome, you guys probably have all heard of this at some point in your training. This was actually introduced back in 2001, and you have to have 2 out of these 4 criteria present in order to meet this definition. The responses that we can meet to this can be bacteremia, sepsis, severe sepsis, septic shock. Now, with that being said, this has ultimately been replaced by several different things. And the reason being it has poor sensitivity, right? So you can have some organ dysfunction, and not be septic, have some organ dysfunction, but not meet criteria, like your kidneys are crashing and all this other stuff. But more importantly, it has poor specificity, meaning at any given point during someone's ICU admission, how many of your patients could meet this criteria, right? So like, I could probably meet this criteria on a bad day. So I'm not septic most of the time. So ultimately in 2016, this was replaced by the sepsis 3 definition. what Sepsis 3 does, it uses something called the SOFA score, or the Sequential Organ Failure Assessment. You guys have probably all heard of this as well. Honestly, it's something we don't do probably often enough in the ICU, but it is something that to be mindful of. So here, what we do with the SOFA scores, or we take several different parameters. So your P to F ratio, or your PaO2 over your FiO2, your platelets, your bilirubin, your MAP, and your GCS score. You get a point for each one of these categories, as you see. The more points you accumulate, the higher your mortality is. So this kind of helps us put a number to things. I'm sure when you guys see a lot of family member, or I'm sure you guys have a lot of family members and things ask you, well, what percentage, what's their chance? Give me a number. Obviously, as you guys know, it's extremely hard for us to give numbers and tell people, oh, well, this is 100% going to happen, or this isn't. But this kind of helps you get a ballpark idea of what that actually is. There we go. Some of the other things that we kind of use here that can be a little bit more clinically useful for us in a pinch is something called the Q-SOFA, or the quick SOFA score. And really, we remember this as HAT. So hypotension, if your systolic less than 100, ultramental status, so if your GCS is dropped, or if your tachypneic more than 22. So any of these things here, if any of these statements are true, you get a point. Anytime you get a point, if you get a score greater than 2, that predicts basically decompensating outside the ICU. So this is something on triage, you're looking more admitting patients. May not be, it may not be apparent at first. You may look at a patient and be like, oh, why are we admitting this guy? This guy's fine. Maybe it's a couple other different things that we saw that kind of tips us towards thinking this. And this is often something we'll kind of use just to help us make a quick decision on someone. However, surviving sepsis campaign is kind of what we do. Society of Critical Care Medicine is kind of the gold standard here. They really paved the way for a lot of things in critical care, and really try to make, obviously, things as best as they can for patient outcomes. The most recent updates came out in 2021. It actually recommends against using the Q-SOFA score as a single screening tool. So obviously, we're taking lots of different things into consideration. It's not just one specific number or thing. Signs and symptoms. So again, generally signs and symptoms in sepsis are super non-specific. Again, it can involve any body part or system. Here I've listed out a bunch of different organ systems and things you may see. Obviously, this is not an all-encompassing list. And there's many different things that you can see, and maybe some things are kind of uncharacteristic. But here's just kind of a list for you to kind of glance at. Again, I don't want to make this painful for you all. So we'll kind of spend more time on the more important things. Some other big things that we need to think about, and this is where you guys really kind of save the day for us a lot of times. To be perfectly honest, we're not the greatest about asking family about things all the time. We kind of have our quick run through things we do, but we may or may not always run through the patient's history as well as we should. So you guys oftentimes are telling us things that we've missed, and it's really important. Past medical history, big thing. So immunocompromised, diabetes, if they have a hematologic or autoimmune disease, obviously HIV or AIDS, splenectomy, surgeries, like if they've had a heart valve surgery, obviously those are big deals. Dental work, surgery, chronic steroids, all these other things. These kind of help us tailor treatment regimens such as antibiotics or antifungals or other things. Really can help make a big difference in patient outcomes. Social risks, so obviously recent travel, alcohol or drug use, very important, exposure to sick people. Physical exams. So obviously physical exam, generally speaking, a lot of the patients may or may not have fever, tachycardic, low blood pressure, increased respiratory rate, they may be altered, modeling from a bunch of pressors, which we'll talk about. Obviously, you'll see memes as we go through here, and again, we all feel it. It's not just us or just you. We all feel this. All right, so this is a busy slide, but essentially what this is saying is kind of looking at the 4 different types of shock. So hypovolemic, distributive, cardiogenic, and obstructive are the ones we see. Just remember the septic shock is a form of distributive shock. So several different kinds. Anaphylaxis obviously is one, but sepsis is the one we're talking about today. So JVP is going to be low here. Your temperature could be, of your extremities could be warm. Remember, you're vasodilated. Could be cold too. Obviously, a lot of our patients end up on a lot of pressors, so that kind of doesn't help make the case for this slide. Passive leg raise. So passive leg raise can sometimes help us see blood pressure increase. IVC is usually non-dilating and collapsing. LV function usually hyperdynamic, but we'll kind of go more into this as we get along. Here we talk about the sepsis workup. This is probably an order set you guys see and you absolutely hate every time you see this drop, because it's a bajillion orders for a good reason. Here are some of the basic labs that you guys probably see ordered a lot. So CBC with differential. This kind of helps us differentiate between is this bacterial, could be fungal, could be something else. CMP, coads, lactate, ABV or VBG. So obviously you can kind of make this a little less painful. And you all, if we just remember that if we ordered an ABG or VBG, we don't have to order an additional lactate and all this other stuff. So trying to cut down on some orders. Blood cultures. So 2 sets of blood cultures. Again, they need to be from different sites. At least one needs to be percutaneously. You can draw these through vascular devices. Do you guys see a lot of, do you guys cut the tips off of catheters a lot? Or has that kind of been recommended against?
No, we typically don't do that as much as we used to, Dalton. And actually, we would prefer that they draw them from 2 different percutaneous sites and not through a central line or anything like that to decrease kind of our collapsy stuff.
Yeah, absolutely.
And if absolutely necessary, take that lower lock cap off and replace it before you draw it, because there's a lot of surface area on the inside of that. And since it's on the distalmost area, it does tend to get colonized with non-pathogenic stuff that, again, we end up treating something that's not real and also get dinged for it.
Yeah. So a lot of those on our end come back as staph epi. So so you draw we'll have a slide later that talks about blood cultures and conundrums of blood cultures. But one of those comes back GPCs, and then a few days later it ends up being staph epi. And now we've given someone bank for, for 3 or 4 days, and here we are. So again, like they said, at least, so here it says at least 1, but per UK, let's do at least 2. So you want to draw before initiating antibiotics if possible, but you don't want to delay administration of antibiotics. So obviously get the cultures as quickly as you can, but antibiotics are life-saving. So if we can get the cultures first, fantastic. If we can't, we'll just have to kind of move on. Urinalysis. So again, UA or urine culture. Again, sometimes we'll order this and the patient will be in stage renal and doesn't make urine. It doesn't usually work for us. So obviously it's not going to be a reality. Cultures. So again, if they've had a recent surgery or have a wound, respiratory culture, joints, all those things. Imaging. So again, you guys will hate us a lot of times when we start ordering a ton of different imaging, when we're not sure exactly what's going on. We usually start with a broad net and kind of reel it in. So sometimes it's necessary for us to get all this different imaging. Procalcitonin, you guys probably see these all the time. Procals are a protein precursor of calcitonin. It helps us as an early predictor of bacterial infection and sepsis. A lot of times sometimes we misuse them truthfully, but what a procal really is intended for is we draw the procal. If the procal is basically negative or, very little, then it kind of helps us rule against a bacterial infection. Obviously, if it's super elevated, it can kind of tip you more towards a bacterial infection, but really it's helpful when it helps you decide against the bacterial infection. Trending them is not really something we're supposed to be doing, or, checking them, multiple times a day. It's not really, sometimes we get in the habit of doing that, but we really shouldn't. Keep in mind that also does not help you identify a source. Even if it's 6,000, it doesn't tell you where the problem's at. MDR swabs. So obviously you guys are very familiar with these, looking for resistant bugs. Can also help us de-escalate some antibiotics, which we'll talk about later. As far as sepsis workup goes on, if we're concerned about a fungal infection, some of the things you may see us order is the beta-glucan and the Aspergillus galactomannan. Occasionally, we'll get a fungal isolator, not usually as frequently as the first two. So the beta-glucan and Aspergillus are kind of going to be our go-to. Some additional studies you'll see us order is the echocardiogram, obviously to check the heart function, see if maybe the heart could be a piece of the problem. You know, obviously if your EF's 20%, it's not going to help your pressure and all the other things. The mixed venous is something that I feel like sometimes we use quite a bit, other times we just completely ignore it. This can also kind of be helpful in some ways, but typically it's only going to be helpful for you if you have a central line in the IJ or subclavian. Ideally, what we're doing here is we're going to draw this mixed venous as close as we can to the right atrium. What this is going to do is we're looking at the saturation on this. We don't care about we do care about the pH and other stuff, but what we really care about on the mixed venous is the saturation. If the saturation is normal around 70%, that's kind of what the normal is. In sepsis or septic shock, it's going to be elevated. You don't have a problem oxygenating, right? The heart's pumping oxygenated blood. That's not the problem. The problem is you're not extracting it. So that'll be your big problem in sepsis or septic shock. Cardiogenic shock or hypovolemia, the number can be low, specifically cardiogenic. Again, not 100% thing, right? So not always 100%. And really, again, it's kind of only helpful if it lands super high or super low. Unfortunately for us, a lot of times it ends up right in the middle and we just kind of ignore it. The other thing that we'll talk about is the MRSA swab, which you guys probably see a lot of these as well. The MRSA swab helps us also kind of de-escalate. It typically results a little bit quicker than the MDR swab. When we talk about de-escalation for the MRSA swab, though, we're specifically talking about if we're concerned for pneumonia. All right, so some management things. So here, I'm going.
Sorry, I was not trying to interrupt you. I was just trying to remind the nurses to draw the fungal isolator. That's that glass tube you order from lab. Don't pull that out of a central line, just like you wouldn't want to pull, you know, a culture out of an old central line.
Gotcha. No, thank you. That's a good point. All right, some of the other things about sepsis. So we'll talk about sepsis management. This is kind of the bread and butter of what we kind of go through here. Again, you guys see a lot of a lot of the orders and everything else, but we'll kind of talk about some of the reasoning as to why we do certain things the way we do and kind of go on from there. So resuscitation parameters, remember to always look at the patient. We get hung up a lot on the numbers, us as providers, and as a team, I feel like sometimes we all get kind of hung up on just looking for a certain number. It's really about the patient. Yes, numbers do matter, but not always. Here are some kind of parameters that we target when we resuscitate a patient. Obviously, everyone knows the NAT greater than 65 for most patients. Again, some patients will set different goals for different reasons, but generally speaking, 65 is kind of our target. Cap refill is something we don't check very often. It is a parameter you can also use. Hemoglobin, obviously, most of your patients will have these at least once a day. Oxygen sats, we're all very mindful of, non-invasive monitoring in the unit. Lactates, urine output, which we're all very mindful of as well. Encephalopathy and renal function. Remember a couple of good non-invasive markers of perfusion, mentation, and urinary output. Cap refill, yes, but the two big ones are the mentation and urinary output. That's going to tell us, are we perfusing vital organs, brain and kidney. We'll talk about transfusions and all this other stuff. Kind of like we talked about earlier, so the golden hour of sepsis, right? So what we want to do is get sepsis early. I'm sure you guys have heard the golden hour of sepsis a million times at this point in your careers. So generally speaking, we want to check a lactate, obtain cultures before antibiotics, broad spectrum antibiotics. We'll talk about fluids a little bit more in a minute, and then we'll talk about the pressors as well. But the first hour is exceptionally important. Getting those antibiotics, getting the patient resuscitated as best as we can. All right, let's talk about some antibiotics. So remember, we want to start with broad spectrum antibiotics and de-escalate based on culture results. So some classic broad spectrum antibiotic regimens that we talk about are vancomycin. I'm sure you guys see this almost daily. You also hear in the literature, some people kind of talk about that this has led to an increased incidence of AKI in some studies. So some people are on that train, some people are not, depends on who you ask, but it's worth mentioning. So if you're seeing a lot of vancomycin or something different, that may be why. Some other regimens include like vancomycin and cefepime. You can add flagyl or metronidazole to this if you want to add some anaerobic coverage. With Zosyn, you're getting Pseudomonas coverage, and you're also getting anaerobic coverage. So that's the reason you don't need the flagyl and the metronidazole with Zosyn. One thing to consider though, antibiotic choices are not a one-size-fits-all approach. Again, this is where it becomes really important to know that patient's history and know like what's going and know if they have any other reasons that you need to broaden beyond that. Remember, like patients with MDRO or other things may need different antibiotics. So vancomycin or vancomycin may not cut it. Some other antimicrobials continued. So again, a good history is imperative. Remember, you got to know what we just kind of talked about. Everyone knows what MDROs are. Again, you got to see culture results and other things, and usually susceptibilities. Usually at this point where you got to kind of dig a little bit through the chart, look at previous cultures, look at susceptibilities and things to try to figure out what would be best. So if they had a Pseudomonas that was resistant to cefepime and Zosyn during your last admission, obviously you don't want to start with those antibiotics. So you'd want to escalate to something different. Meropenem, maybe they need a dose of amikacin or a restricted antibiotic if it's really severe. A lot of times you'll see those in like CF patients that we take care of that, have had tons of different antibiotics and maybe there's only a handful or a restricted set of antibiotics that they need. Most of the time when you get to that point though, it's really an infectious disease consult that's going to be important. MRSA, obviously we see this every single day. I would argue maybe a lot of us probably have it at this point. VRE, so vancomycin resistant Enterococcus. Again, we'll have to consider something different than vanc, right? So linezolid or daptomycin or some other options that you may see. Then ESBLs, sometimes we'll end up with carbapenems and things. Okay, so fluids. Crystalloids versus colloids. So remember crystalloids that we learned in school, things like LR, normal saline, and plasmolite. Colloids include blood products, so like albumin, blood, things like that. The moral of the story here, crystalloids are a lot cheaper and have about the same result. So that's why we use crystalloids preferentially. Plasmolite's kind of the exception. Plasmolite's a little bit more expensive as well. So 99% of the time you'll see it's using LR or normal saline. Things about normal saline. Some studies have shown, again, depends on what school of thought you're in. Some people aren't the biggest believers of this, other people are. But normal saline in some studies has shown an increased incidence in metabolic acidosis and AKI due to volume expansion. So a lot of times you'll see us preferentially use LR, and that's the reason why. Some other studies have shown the potential survival benefit in critically and non-critically ill patients with LR or balanced crystalloids. So it's kind of the reason we preferentially use LR, but it's not wrong to use normal saline. Again, depends. Some people believe this more than others, but it's kind of why we preferentially reach for LR. Again, it's not a one-size-fits-all approach. Remember that if your hemoglobin's 5.5, you should probably give blood first. That's kind of your primary problem, right? So it is okay to use blood or albumin in certain situations, but 99% of the time, I'm preferentially going to use crystalloids. Previously, the target in fluid resuscitation per SCCM was 30 mils per kg of crystalloid fluid for resuscitation. Now the guidelines in 2021 recommend at least 30 mils per kg. What they say is, if you're responding, you can actually give a little bit more. It always kind of becomes a little tricky. how much is too much, all those kinds of things. We want to stop if they're, if you've given more than 30 mils per kg, they're still hypotensive, or if you're giving the fluid and they're still dropping exceptionally low, obviously we're going to have to start pressors. If the patient starts developing some side effects, so like, let's say you give them a bunch of fluids and now, they started on room air and now they're up to 2 liters, 4 liters, 6 liters of oxygen, you should probably stop the fluids. So just keep those things in mind. That's kind of clinically is one way to monitor it. The other way to kind of look at it is with some of the, one of the clinical ways to look at it's that. The other way is heart rate. So, right, if we're giving fluids, the heart rate's coming down a little bit, that's usually a good sign. You can look at pulse pressure variation, a little more tricky. A lot of times you'll see us break out the ultrasound. Ultrasound's a great tool. You'll see us looking for someone's IVC specifically to see if it's collapsible or not. If it's collapsible, we'll usually try to give a little bit more fluid. If it's nice and plump, then we kind of know, okay, maybe they're in a good spot with fluids. Let's move on to pressors. We no longer use CVP as a static marker anymore. Again, SCCM kind of recommends against it. Again, you want to also consider patient comorbidities. If you have the patient with end-stage renal disease who's anuric, you don't want to slam them full with a bunch of fluids and not be able to do anything about it, especially if they just had dialysis. Sometimes we'll call that the call of shame. So if you've over-resuscitated someone and they've already had dialysis that day, and you go back, hey, I'm sorry, I need you to come back and dialysis again. I messed up. It's okay. It happens. Moving on to vasopressors. So again, everyone in this room could tell me that norepinephrine is the first line pressor. You guys see us use this almost every single day. Some studies, again, are going to suggest that early administration may stabilize shock actually faster. So depends on what you read, depends on who you talk to, but that's one of the other things. There are no specific recommendations for second vasopressors. It's kind of dealer's choice here. You do want to tailor them to the individual patient. However, so we'll kind of talk through that in just a second. Down below, you can kind of see a table here where I've listed out just a few. I mean, obviously there's some more pressors out in the world, but these are just a few of the ones I feel like we commonly use here in NICU. So norepinephrine, epinephrine, phenylephrine, and vasopressin are things you'll see quite often. Here we kind of look at their mechanism of action. So you can see alpha receptors, beta 1 receptors, and beta 2 receptors, and then other just for different receptors. So norepinephrine primarily acts on the alpha receptor. So this is going to increase your SVR or increase or cause constriction. You do get some beta 1 activity, which is you do get some beta 1 activity. Epinephrine, however, a little bit of alpha, but mostly beta activity, right? So beta 1 primarily, so increased contractility and all those other things. Beta 2 and some beta 2, which is like bronchodilation and other things as well. Phenylephrine, I should have put it here, is strictly alpha. So strictly alpha. Phenylephrine, though, just keep in mind, is also a synthetic pressor, so it's not actually endogenously made in the body. So norepinephrine, epinephrine are made in the body, obviously, but phenylephrine is not. Vasopressin acts on a completely different receptor, so it does not act on any of your catecholamine receptors. Some of our reasoning, so norepinephrine, again, think about your problem in sepsis. You got this widespread vasodilation or whatever. So it kind of makes sense that you want to drive up your SVR, right? You want to increase your, you want to do your do some vasoconstriction and kind of get that out, but you also get the benefit of a little bit of beta 1 here. So it kind of gives you that. That's why it's more of an ideal drug for septic shock. Phenylephrine, so a lot of times people will think, oh, well, phenylephrine is pure alpha. Like, why not just use phenylephrine? Phenylephrine is kind of a weaker pressor. It's a lot of volume and it's synthetic. So not as great as norepinephrine, really. And you don't get a little bit of the beta 1, which is nice. Talking about other pressors, it's really kind of helpful to think about the cardiac output equation. So cardiac output's your heart rate times your stroke volume. Remember that stroke volume consists of preload, afterload, and contractility. So each of these drugs kind of acts on, except vasopressin, kind of acts on these different things, right? So your preload comes down to volume, so that's kind of what it is. But afterload, comes with increasing your SVR, your systemic vascular resistance, and then contractility. Obviously, you're going to get a lot more of this with the epinephrine than you will with any of the other drugs. So a lot of times, choosing the second pressor, it's really based on the patient's clinical condition. So let's say we start some levofed or some norepinephrine. We get the patient, the patient's on 0.2 levo, their MAP's still 60, and we need to add a second pressor. Technically, you could add any of the ones on the list here, but think about it from a clinical perspective. If their heart rate's 130 and they're on 0.2 levo, a lot of times we'll reach for the vasopressin as a second pressor. And the reason being is it's not a catecholamines. It's not going to act on this alpha or beta receptor. It's not going to drive your heart rate up further. A lot of times that's why we steer away from epi, use the second pressor, because if your heart rate's already 130, if I add epi to you, it's going to jack your heart rate up even more. And so again, any of these pressors are not wrong to use, but that's why we preferentially use some over the others. Another pressor another thing you'll kind of hear about is like this low dose dopamine. It's not low dose dopamine. It's not actually renally protective. That's kind of been a myth. It's kind of got busted. But again, you may hear about dopamine on other floors or other services. So it's not wrong. I don't feel like we use it very often, but occasionally you might see someone use it. Normally, again, always levo first, and it'll most of the time end up with vasopressin second. Phenylephrine will commonly use, obviously, during like an intubation or something, just to kind of get some less pressure up. And then obviously with this, the central and arterial line is going to be very important if we're on a lot of pressure. Another thing to kind of keep in mind is hypoxemia and ventilation. So, septic patients may simply require more oxygen. The demand of the body. So you can take your work breathing can actually account for 40 to 50% of your energy expenditure in septic shock. So if you think about that, you're using 40 to 50% of your body's energy expenditure. You're very sick. You're probably not getting much intake or anything like that. It's very, very easy to kind of throw this out of balance. And these patients sometimes end up needing intubation or mechanical support for the blood. So it's not uncommon, and that's okay. Ensure it's not iatrogenic, right? So it's not, if you start seeing oxygen requirements creep up and you're still slamming with fluids, stop the fluids. Time to move on to the pressor, and then give adequate, oxygen or ventilation support. All right, some stress dose steroids. Sorry, I had to poke some fun at the Liver King, who is not on steroids, but is on steroids. Anyway, so stress dose steroids, these are used in refractory septic shock. So again, this is like after you've done fluid resuscitation. At this point, you're on 2 pressors with escalating requirements. So it's not something we lead with, but here we are. This is best if you're suspecting adrenal insufficiency, right? So like if you think that there's a chance that the patient could be adrenally insufficient, this is a really good thing. This can be a really good thing to also do. The one thing we occasionally do that we should not do is cortisol stimulation tests in the ICU. Occasionally you'll be asked to do these. It's not usually a good idea to do a cortisol stim test when someone's critically ill. Most of the time it ends up being critical illness related corticosteroid insufficiency. So it's not necessarily truly adrenal insufficiency, but it's because someone's super sick, and here we are. So cortisol stim tests are not exactly the best thing to do in the unit, but occasionally you'll see this thing. How we do this is we typically give hydrocortisone. We give 50 milligrams every 6 hours. That's kind of what we do in the UK. The recommendation is 200 milligrams daily. You can divide that up however you please. Some places will do 100 milligrams, Q12, or however they divide it up. Doesn't really matter. 50 Q6 is probably a better idea, just simply because it spaces out the steroid and everything else. Kind of helps you regulate blood sugar and things a little bit better. Obviously, steroids don't come without risk. You're going to immunosuppress someone with this much because it's quite a bit of steroid. It can lead to super infections and then obviously metabolic derangements, kind of like you guys probably learned, it's like hypercortisolism and all these other things, right? So like it can drive up your potassium and other different things like that. So not without consequence. Some other adjunct therapies and considerations you may see us do. Bicarb. So bicarb we typically reserve for patients that are very acidotic. A lot of times when your pH drops below 7.2, the body, the vasopressors typically don't work in the body as well. When the body becomes more acidic, it has problems tolerating vasopressors. So if someone's super acidotic, you may see us reach for bicarb occasionally just to kind of help, temporize that and let the pressors kind of take their effect more. Obviously, you guys have all used bicarb at some point. You've seen it's very transient in its effects, right? So you immediately, or you'll pretty immediately get a pretty good response, right? Like you see a big shift in the blood pressure and everything, but then, not long after it kind of tapers off. So we typically only use that if it's less than, or if your pH is less than 7.2. If you're above 7.15, it's kind of a hard argument to make. It has no direct role in septic shock. Calcium is another one we don't often use as much as we should, but it is very helpful. We sometimes call it the fifth pressor. It's often low in critical illness. If you're given a bunch of blood products, obviously it can be chelated by the blood products. So again, going back to the scenario where the patient has a hemoglobin of 5.5, if you're given 2 or 3 units, you should be given some calcium as well, because it's going to be accumulated and be low. Nutrition is also a big point that we kind of talk about in the ICU. You want to feed as tolerated, but you may not be able to depending on your vasopressor dose, right? So if you're on like 0.3 levo and then vaso, probably not a good idea to be, giving people a ton of feeds. You don't, and even when you get to the point to where you can start feeding the patient, so if you're off the vaso, maybe you're down to like 0.06 or 0.08 of levo, and you're wanting to feed the patient, that's great. You don't have to give them full-fledged feeds. Really, what you're looking for here is just to maintain gut motility and things like that at this point. Euvolemia. So euvolemia, obviously trying to get back to baseline. You guys know one of our favorite medications in the world is Lasix. We oftentimes have to come up with a reason not to give it rather than not give it. So what we found with this, and this really comes back from the study back in 2012 called the FACT trial. And what this does is we found that it decreases mortality risk all throughout the hospital, not just necessarily in septic shock patients or whatever patients, just in general, it decreases mortality risk to be euvolemic or to be euvolemic. So again, the reason this becomes important is think about all the fluid you're giving up front during septic shock. If I'm 100 kigs, you're going to give me at least 3 liters, probably 4, maybe 5 liters up front. So quite a bit of fluid. So de-resuscitation is actually just as important as resuscitation. So after we come off pressors, after we can leveled out, patients doing clinically better, then you guys will start to see some morning rounds, start to order the Lasix, and you're just like, oh, God, here it is again. So just keep that in mind. Prophylaxis, obviously, these are just routine ICU things that we should be thinking about all the time. DVT prophylaxis, Lovenox, heparin, STDs, whatever it may be, and GI prophylaxis for stress ulcers, so famotidine or PPI of some sort. Head of the bed, being up, helps prevent aspiration, decrease cerebral edema, all that. Now, the cultures that we're talking about. So remember to pay attention to the species and the time it takes for bacteria to grow out. So going back to earlier, drawing from tips or drawing from central lines that have been in and stuff. Remember that the example here could be staph epidermis, right? So this is one we see a lot. This is maybe it's not pointing fingers at anyone. We do it too. Maybe we put the line in and didn't clean as well as we should, or whatever got on the line. Staph epi is a common contaminant that we see. So for example, take an example of staph epi at 2 days and 14 hours. This is likely a contaminant, right? It's taken a pretty long time to grow back. Staph epi, the patient's clinically fine. It's probably a contaminant. However, let's, if we flip the script and it comes back at like 8 hours, something comes back at 8 hours, that's pretty serious, right? That's pretty bad. So the quicker something returns, the more likely it's real, and the potentially more serious it is. A couple things we have that are kind of nice is the reflex result you'll see. It's a blood culture identification panel, helps us identify bacterial resistance genes and more rapidly from a positive culture. So this really kind of helps us guide early decision making. So if you see us shuffling around or changing antibiotics around, this is why. A common one that we see is like the MECA gene. For example, this may indicate some kind of resistance mechanism. Let's say a patient comes in with, they come in from home or something, they come in and you start them on cap coverage with, Azeth and Rocephin. So kind of, outpatient, kind of wimpy coverage, right? And then you get a blood culture back and boom, MECA gene. Well, that kind of indicates a problem. Usually you'll see us thrown on vanc pretty quickly. Or if we see it coming back, so they're already on broad spectrum antibiotics, you probably won't see us de-escalate until we get more data back. So again, kind of a helpful thing to help us, coordinate or figure out what exactly is going on with the patient. So some other clinical pearls that we'll kind of run through here. You guys have probably seen a lot of these. Again, a lot of familiar faces here. So you guys have all been in the NICU before and done quite a bit. Instrumentation is kind of important, right? So a lot of times we'll have patients go for stents, surgical procedures, IR procedures. Sometimes this is a necessary evil, but don't be surprised if they come back looking a little worse. A common one that we see might be, especially like someone with like a infected, kidney stone or something. They go to the OR to get it taken out, and then they left on 0.08 of levo, and now they come back on 2 pressors. Not uncommon, right? So you went in, you stirred up a bunch of bacteria and released it. Unfortunately, sometimes patients get worse before they get better, and that's okay. We kind of anticipate that at times. Gram-negative and gram-positive infections, not a hard and fast rule, but generally gram-negative infections are a little tougher to treat. They happen more quickly. So you see someone get really sick really quickly. A lot of times if we don't have any data or anything back, we'll kind of consider that, hey, that may be a gram-negative infection. You may see us double cover. If we're really concerned about a gram-negative infection, you may see us double cover with maybe some amikacin or an aminoglycoside front. Again, not all sepsis is bacteria or bacterial. Remember, depending on the patient population, you may have other things going on, fungal infections. You may suspect, meningitis, which is not always bacterial. It may be viral meningitis. So again, lots of different things to consider. Here's some additional drugs that you may see us use if we're specifically worried about meningitis. So acyclovir for the antiviral coverage, and ampicillin if we're really concerned about listeria. I know ampicillin is kind of a pain for you all because it's like every 4 hours. So not the most friendly antibiotic to be given, but sometimes a necessary evil. Fungal infections. So again, we consider these mostly in severely immunocompromised patients, HIV, AIDS, patients getting chemotherapy, things like that. Again, we kind of talked about the basic fungal workup already. A lot of times we'll see Candida as one of the more common species we'll see around here. Again, you got to be careful though with Candida because sometimes you can get some of the species are a little bit more harsher than others. Glabrata and these other Glabrata and some of the other ones are a little bit more resistant and may need different antifungal coverage than our standard antifungal coverage. Albicans can kind of vary as well, but the treatment we typically start with is microfungin, which you guys have probably all seen. Sometimes we'll escalate to azoles or amphotericin, other things. Another thing you may see us do is if we're worried about it, if we diagnose someone with a fungemia, you may see an ophthalmology consult. Pretty sure I spelled it wrong on here, so I apologize. But you may see an ophthalmology consult, and this is to really rule out like fungal endophthalmitis, so fungal infection in the eyes. They can lead to blindness. So something you don't want to miss, and that's the reason for the ophthalmology consult. Some other things that are really important: source control. You must search relentlessly for a source. The problem, ultimately, you may temporize the problem, but it will never get better until you locate the source. You got to find the source and achieve control. Again, you want to do a comprehensive history and physical. It's really cannot state the importance of a good history and physical. It's very, very important. And a lot of times you guys find a lot of things on physical exam or in the history that we didn't find or missed. So it's very, very helpful and very, very pertinent. So you guys always do a great job at that. Again, always consider hardware or old lines. If someone has lines from outside the hospital, obviously you know how we feel about those. Not great. If they have tunnel lines, pacemakers, artificial joints, all these things can be a source for infection. Again, we'll have to consider additional imaging. Maybe they had a recent surgery, so maybe they need to go down for a scan to make sure something hasn't happened in the area. The other important thing to this is to be a good steward and de-escalate. Sorry, my dogs are going crazy. My other thing is to be a good steward and de-escalate when possible. Antibiotic resistance is a real thing. A lot of our patients now have, all these horrible infections you guys have to wear gowns and stuff for just to, provide basic care. So antibiotic resistance is real, and if we can de-escalate, if you guys think we can de-escalate, definitely give us your input. Another thing that we saw really commonly during COVID, but we occasionally see now as well is ARDS, right? So acute respiratory distress syndrome. Remember for ARDS, pneumonia and sepsis are the two most common causes of ARDS. Okay, so pneumonia just recently took over as the most. I feel like it's not really fair because that's obviously pneumonia is pneumonia, but whatever. Pneumonia and sepsis, two most common causes of this. ARDS physiology we could talk about for hours. I know you guys don't want to do that at almost 6 o'clock on a Thursday, so we won't do that, but we will talk about how to diagnose ARDS. We use what's called the Berlin criteria. So this came out quite a bit ago. I think it was like 2000. I forget when the Berlin criteria came out, but it's been out for quite a bit. And these are the criteria that we have to meet to diagnose ARDS. You have to have a P to F ratio of less than 300 on a P greater than or equal to 5. So P to F, PaO2 divided by your FiO2 in a decimal, less than 300. So for example, if if I'm on 100%, the bottom number would be 1. If I was on 80%, it'd be 0.8 that I'm dividing by. Let's make it easy. Let's say we're on 100% oxygen and the PaO2 is 70. My P to F score will be 70. Okay. P greater than or equal to 5 is also very important. A lot of times when we're getting called for consults on the floor, they'll be like, hey, I think my patient's in ARDS. We're like, okay, cool. How much oxygen are they on? They're on 4 liters. Okay, it's not ARDS, not yet. Maybe heading there, but you can't say that yet. You also have to have bilateral infiltrates on your chest X-ray, non-cardiogenic pulmonary edema, which is also very important. Non-cardiogenic means it's not heart failure, right? Because if you have heart failure, volume overloaded, then it's just heart failure exacerbation of volume overload. And then you have to have an inciting insult within 1 week. It's not a spontaneous thing. There has to be something that has triggered this. So also another very important point. Again, you guys are probably all familiar with this, but we'll talk about it. How to manage ARDS. You'll see us, there really should be, 4 to 6. So you want to target a tidal volume of 4 to 6 moles per kg of predicted body weight. What this basically the reason this became important is because through ARDSnet and all these other landmark studies, they figured out that low tidal volume ventilation is really one of the hallmarks to treatment. There is no direct therapy for ARDS. The only thing you can do is minimize the damage and give the patient the best chance they can to recover. Low tidal volume ventilation is one of the hallmarks of this of ARDS treatment, specifically because it prevents you from, it tries to prevent from doing as much volume trauma and barotrauma as possible to the patient. So minimizing the damage. You want to keep your plateau pressures less than 30. So a lot of times patients may be in all different kinds of modes for ARDS. Usually it's volume control, PRVC, or not often, but sometimes pressure control in ARDS. But really what we're trying to do here is keep the plateau pressures less than 30. So we may have to flip them over to volume control to check this plateau pressure and make sure it's less than 30. A good rule of thumb, obviously peak pressure is the sum of all your pressures. So if your peak pressures are really high, that can kind of tip you into being a problem. So if my peak pressures are 40, I need to check a plateau and make sure it's still less than 30. If my peak pressures are 25, then I'm okay. I don't need to necessarily check my plateau pressure immediately. Proning has shown benefit early in the course of disease. So proning, what we found from the studies is that proning for prolonged periods of time, meaning greater than 12 hours at once, is beneficial in early disease. So it's not something you're going to do 2 weeks into the disease. It's something you're going to do, within the first few days. We don't know the ideal time, but we know that anything greater than 12 hours is beneficial. Here at UK, I believe we do 16, and then 16 hours prone, then 8 supine. Antibiotics, again, are for sepsis. They're not directly for ARDS. You don't treat ARDS with antibiotics. You're treating the inciting injury, whether it's pneumonia or sepsis. Paralytics, these have kind of been debunked. Initially, we kind of thought paralytics had benefit early in the course of disease, but later we learned that paralytics actually don't necessarily improve your mortality. They do become beneficial maybe with horrible, ventilator dysynchrony. So you may be using a lot more sedation before you put these on board. Again, de-resuscitation is just as important here, right? So again, we've resuscitated someone for sepsis, got all their fluids and things, they develop ARDS, we also have to consider de-resuscitation as well. Any questions? I'm sorry, my wife.
Well, I have a question.
Yeah.
This is going to be highly tailored to, nursing and our role here at UK. What if you had to pick one thing that you wish nurses understood about treating sepsis to make the care flow better? What would it be, basically?
That's a very difficult question. Honestly, no, it really is, because honestly, I feel like you guys do such a great, I feel like as a team, we all do such a great job with sepsis, because we see it quite a bit. Man, it's tough. I have to think about that for a minute, actually. I mean, again, I really feel like everyone does a really great job with this.
Well, you mentioned it's a team approach, and that's definitely true. I know that one thing, it's overwhelming, that golden hour, as you mentioned, that first hour can be like a lot. And this is when you got all your friends in your room. Some of these patients don't, if you get somebody up here and they're in bad septic shock, I might rethink some of the things that we tend to do reflexively that take forever, like changing a Foley or doing a bath. Getting those antibiotics started early has been one of the single largest mortality reducers. I think, what do they say? I think they changed the estimate. It used to be for every hour is delayed at 7% increased mortality. I think now they've upgraded that to like 12%. So I know that when they redid the guidelines, they really emphasized getting those antibiotics in. So if you're not able to get, cultures, call me, charge somebody who's ultrasound trained if we need to go that route.
Yeah, that's a great point. Honestly, generally speaking, I feel like, as a team, I feel like we really get a good handle on it. So it's, these are only small, minor improvements, but I think that's a great point.
And we very rarely encounter patients the minute they go septic too. I mean, a lot of times they were on the floor and declining, or they were in the ED, or they were transferred from another hospital, right? So we don't get to see them in that classic picture a lot of times. So it makes it more challenging. But yeah, we're very good at sepsis. Going to other ICUs, I think that we, this is what we're very good at. We're not, this is not most of these shouldn't be new concepts, but it's good to know the why about what we do.
Absolutely. And if you have, really the best place to read about this stuff, SCCM is great. offer a lot of good free resources and things, and it's where most of the information from this it actually comes from.
And they have good infographics and stuff like that too.
Yeah, absolutely.
All right, well, if we don't have any other questions, I have everybody that's on the chat in the attendance, and you guys are give you 3 minutes back. Our next date is, and thank you so much, Dalton, for hosting. Our next date's going to be the Sim Lab, and that's on, I believe, the 22nd, and that's in person, obviously. So anybody who doesn't know how to get to Sim Lab, it's just in the old hospital as you're going out on the 2nd floor. So I'll send an email reminder.
Thanks so much, Dalton. Appreciate you, man.
No, thank you all. You have a good
All right.
night.
Thanks,
Hey,
everyone.
I had one quick question about drawing out of lines because I want to confirm. So obviously, I don't think any of us were ever taught to draw out of older lines. Are we moving away from drawing from even brand new lines too?
I think the recommendations on that from our end are only if it's just been placed. So if you've been infusing a bunch of crap through it and drawing labs, certainly if you've drawn labs through it, you've probably already contaminated it, even to a small extent. So they really don't want us to use those lines unless it's just been placed. So like right after they verify it, or even when they're still in the sterile field, you can say, hey, Dalton, could I have, 2 10 ml syringes of that? And I think
Okay.
they're okay with that.
Okay.
Yes, totally agree. Yes.
Okay. Sounds good.
They come from the floor, they're septic, they got a PICC line. Even after changing those lure locks, and unfortunately nationwide, I think a lot of people are still getting cultures from lines and stuff like that. I think UK is probably a little bit better than the average, just because we tend to be on the edge of research a little bit.
Yeah.
But some of our travel nurses may not have been in facilities where that's as important, and that's where we really need to protect our institutions numbers, and really all of our numbers, because now our raises are involved in it. Yay.
And also we had one of the fellows asking or ordering people, and the word was adamant about drawing from a central line too. So we're kind of fighting it on multiple kind of levels. But
yeah, I had that experience. I did want to know too, like some of them are like, we need to know if it's this line before we do like a site change. Can we just be like, hey, if you're even thinking about it, just do the site change, or can they culture the catheter itself? Are those options?
We typically don't culture the catheter itself anymore. That's something that we kind of used to do a long time ago. I mean, if anybody has done it recently, please correct me if I'm wrong. But yeah, I would, if it's in the catheter and it's a eclampsia, then it should be in a peripheral stick as well. So, the risk of getting a contaminant from the line is just so much higher that clinically you want to treat something that is really a central line bloodstream infection and not a contaminant from the line. Does that make sense?
I mean, really, at that point, we should also if it's sorry about it, if you're considering it's the line, you should just take the line out, because it's going to eventually.
If you think about it, it will take at least 24, 36, 48 hours to get meaningful data from your culture. And if you're still maintaining that plastic in there, that is a lot of time that you've wasted that you could have removed and gained source control. So really, if there's any question about it, I think they really want us to do that. 15 years ago, it was very common to remove a line and culture the tip. But I don't think that that's hand out to anybody's benefit. I think that CMS has probably had something to do with it, but also, again, if it's the line and you pull it, your patient will clinically improve. If you pull the line and it's not that, then you continue to treat the infection. Good question, Emma. obviously we're very protective over our CLABSI numbers right now because we just had a huge uptake. So Adam and I have passion responses too.
Yeah, we do. And, it's the right thing for the patient. And, all of your all's raises are kind of built into that. I mean, obviously it's not going to be focused on just that one marker, but, we did so good for so many months, and to have so many in such a short period of time. Brian's right. We're pretty passionate about this right now.
And part of it too, again, not to, sorry to keep butting in, but like, if we have time, unless it's a code or something like that, if we have time, like the provider has time, encourage them to do like an IJ. There's really, I think we've been doing a lot of thin lines recently. And again, unless like you're kind of pressed for time, like the patient's coding or something, then we should make more of an effort to do clean, like a IJ or a cleaner.
Yeah, we're noticing site selection and line necessity are two kind of big focuses that we're kind of focusing on right now. But we had a really good conversation with Jason, the chief fellow, which I didn't even realize there was a chief fellow, but about getting that information out to everybody. So we're all kind of just on the same page about, what the right thing to do for our patients is to prevent these things. So you guys don't have to fight those battles and say, hey, let's not go for the FEM, let's go for the IJ. They're already kind of playing in that because we've already had all these conversations kind of thing. So.
All right, well, I'm going to go ahead and end the meeting then. Those of you who are working, we'll see you soon. And those of you who are off, have a great rest of your evening. Bye.
Thanks,
Thanks, everybody.